Our next speaker is going to be Dr. Sahil Goel, who's again a consultant cornea and anterior segment surgeon in his private practice and also practicing in Dayanand Medical College and Hospital in Ludhiana. And he's going to tell us something even more tough, trapped in a black hole. And I just got a very tiny glimpse of his video, so I really want to know how he dealt with it. So on to you, Dr. Sahil.
Very good evening, everyone. This was the first eye, minus 6.5 diopter sphere, no cylinder, what I would call an ideal case for a lenticule. Left eye, unfortunately, at the end of laser firing, showed such a large area of misfire. We had never seen such a large area of misfire. Now, ideally, this case should be abandoned, and after a couple of months, PRK or maybe if at all a femtolasic could have been planned. But I think we end up putting ourselves in a lot of pressure when we commit to the patient next day visual recovery. This particular patient was an NRI patient who was here in India just for less than a week, and the treating surgeon had promised him within a couple of days normal vision. That pressure sometimes makes us take bad decisions. Now, this case, as we have already talked about, whenever you see a black spot, black island involving the pupillary area, we ideally should not touch it. And in this case, as you can already see, the half the pupil seems to be slightly visible. Any case, at the end of the laser fire, you can see from behind at the interface PI, you see some of these deposits. And when you take off, you see this kind of deposits at this plastic interface. It could be easily scraped off with finger. Any case, these were the energy settings, anterior 41, posterior 43. This was just 3 months when we had started doing our cell colorita platform. So, as I said, and I would like to repeat, ideally, it should not have been proceeded. But in any case, when the decision was taken to proceed, this was how it went. Anterior plane, posterior plane. There was a lot of resistance in the anterior plane as would be expected, specifically the superior half, more so on the supratemporal side. Now, this particular area, because the laser had not fired despite multiple attempts, it was really difficult. But anterior plane, we could still get through. At the end of it came the real challenge, starting or entering the posterior plane. If it were the inferior half, we could have gone in the superior half and maybe peeled off like shown in earlier videos or tried a lenticular rhexis. But as you can see, despite taking a blunt dissector, we could not enter behind this area. And ultimately, because of a lot of resistance, the surgeon ended up perforating, as you can see here, perforating the lenticule. It was a 4.5 diopter, around 55 micron lenticule, but still with the dissector, it ended up perforating. And as you can see here, this was the only area probably where laser had fire, and this was the only area where surgeon could enter the posterior plane. This entire was a barrier which prevented the surgeon from going and crossing this barrier in the posterior plane, reaching what was otherwise a smoother area of dissection. So this area and this area we could not enter. And now that there was perforation in the lenticule, we had already crossed point of no return. Before this, if we had stopped, we could have easily converted into a femtolasic or PRK later. But now that the lenticule is torn and distorted, it had to be removed. Now, the surgeon tried to go inferiorly and tried to scrape off the lenticule. When it did not work with a smooth instrument, what was tried was a Sinski. So with a Sinski, we tried to scrape off the lenticule and finally we could get that edge here. All through, multiple small edges were picked up. And because this area the laser had fired, ultimately this half was dissected and we tried to peel off using a forceps. So when we had enough lenticule separated, that forceps could grab the end. We tried using the forceps and tried initially gently and later with slightly higher force, peeling off the lenticule, gradually pulling it towards the main incision, as you can see. Inferiorly, the amount of resistance or the force applied was lesser, but gradually, as we kept reaching superiorly, the amount of resistance increased, the amount of force needed increased. The idea was if we could peel off the superior... Hi, Dr. Rishi. So idea was if we could peel off and bring it to the superior pupillary area at 12 o'clock of the pupillary margin, at least we would have cleared, and we were fairly able to achieve it. So now, as you can see, the lenticule has reached almost superior pupillary margin. This much area was reasonably clear, but now rest of it is stuck. As you can see, we are trying to pull out, but with such pressure, the lenticule itself, the way that it is holding is peeling. So ultimately, we had to convert to a semi-flap because we did not have circle software. Caesar was the only option. It looks very crude. Even we did not have the Caesar at the laser center. We had to get it from another place. With the help of another person, retracting the lenticule, a crescent was used. Blunt dissection was carried out by opening it up like a clex. So this area we had already dissected. The rest of the area was dissected using crescent. Just at the edge of the area, we had these two islands of stromal tissue on the bed. This particular island and this particular island, which was scraped off using crescent because this area the laser had fired. After scraping, there was still small area of island left over here, which was ultimately held with vanas and cut with a scissor. We continued to smoothen the bed. You can see the edge of the lenticule. This was the wall, which was the edge of the lenticule. The stromal bed was hydrated. Again, try to see if there is any residual stroma. And then finally, the interface was washed and the flap was reposted like a hemi-LASIK flap. At the end of this, we were not sure what we will get. We had our fingers crossed. The patient had to return back to his country after a week. We'll come to the results later, but I'll take you to the video of docking. As you can see, while docking, there was absolutely nothing wrong on the interface. The surgeon even cleaned the cornea with a sponge. But as you can see, I'm going to pause here. There was a small area which you can see a sort of a black pattern, which was initially not seen. This area, if you can now gently see, there's a very small, very poor contrast, but this particular area, you can see some deposit here, which came after the applanation, which was not there before docking. Now, this was what it looked like at the end of laser fire. So, though we could get away with it, but it's not the ideal case scenario, and we have to be cautious while promising next day visual results. This is how the patient's topography look 3 days post-op. As you can see, this is anterior axial and tangential curvature. There seems to be slight asymmetry, but if you look at the actual numbers, it is 39.3 and 40.3. So the asymmetry is only one diopter. Grossly, the surface looks relatively uniform. And as you can expect with this topography, patient was 6'6" on day 1 itself. To look at more subtle changes, that the tangential curvature also shows relatively uniform. There is some extra flattening superiorly, but if you look at the numbers, the difference in inferior and superior is not more than one diopter. If you compare and contrast this particular topography with the fellow eye, the fellow eye looks a lot more uniform, but surprisingly, the fellow eye at day 3 was 6'9" or 6 by 7.5, and this complicated eye was 6'6", and the patient did not complain of any visual problem at day 3 itself, which is something we could not believe our eyes with. So we got lucky, we could get away with it, but then I would like to reiterate that you find a black island in the pupillary area, do not give yourself a heart attack. It is best left alone for a later date. Thank you so much.
Yes, Sahil, that was brilliant. And I tell you, you are a very daring surgeon to have done what you did. But you know, in our microkeratome days, and that too, where there was so little information about, we've done very, very difficult situations. But you know, we were very lucky to come out of it. It just tells you that the cornea is truly very
Very
forgiving.
forgiving.
The message is that we do not touch these eyes. Now, our next question is, if you do not touch these eyes, that would you do a surface ablation on the same sitting? Shesh, I want your thought on that.
Silk platform is there is a illumination button in the right knob, and that's usually at low. And if you turn it high, these subtle interface deposits get highlighted better. So it's probably always a good idea to keep the illumination high at the time of dock, because unlike in the Visumax or other platforms, you don't see a live picture happening, and it's I mean, only at the time of dock. During the laser delivery, you don't get a live picture.
Right. So there are two illumination buttons. The left side is external light, the right side is internal light.
Internal light.
What I've done is external light left side, I decrease it to 50%, and internal, I increase to maximum. Retrospectively, I was able to see in the video that there was slight interface deposits, which was not there before docking, which was seen only after docking, but now we are more alert about it.
So then, Rishi,
Ma'am, I'd like to add a point here.
When would you do surface ablation?
No PRK same sitting. I'm sure everybody will agree.
Yes.
Ma'am, I'd like to add a point here.
Yeah.
I really like the word that Dr. Sahil used. I wanted to add it in the previous dark spot presentation also, that we need to identify between a spot and an island. A spot can be taken care of, an island cannot be. This is clearly an island. It's a very big zone and it is not supposed to be touched. And I think regarding your question, if a PRK
Entire
on a same
continent, it's
sitting,
not an island.
it is an island. It is not a spot. So an island should not be
It's an
touched.
entire
A
huge
spot can
island.
be. Yeah. So I really like that important catchphrase here is that if it's an island, please don't touch it. And another thing that regarding the second sitting thing, if you're planning, like in Visumax 800, if you're planning your the cap at 130 or 120, regarding the same sitting, you can wait for the OBL. We've done it because once we had a case where there was a complete island, there was no fire area. And so we made the patient wait, cleared the OBL, and we took the patient for a 90 micron flap cut. We did not do circle. We were that time not trained enough to use it, and we wanted to use it in front of the engineer first. So we made sure the OBL is cleared, and we took it at 90 flap cut, and then we did the procedure at the same sitting if there was an island.
I still feel that a surface ablation should not be done at all in the same sitting, because we will not get the kind of accuracy in our results at all. There would be
No,
an
not a surface ablation. We did a flap intralace.
So even if you do an intralace, you would have some regression and you would end up with a small residual error. Even a suction loss, if you do the other measures which are suggested, you have to be prepared that there could be rarely regression in our refractive correction. So very good, Sahil, what you showed and documented also.